This week on the BackTable podcast.
The optimistic says drug-coated balloon will replace stent. The pessimistic said forget it. I think we have to be realistic, but I think if we learn how to do it, 30% substituting stents today with drug-coated balloon is very realistic. I think for instant restenosis, maybe it's 80%, but instant restenosis is only 10% of the market. So we really have to look on de novo and remember the mantra, leave nothing behind. If you leave something behind, it's always an issue. If you do it with drug-coated balloon, you can still put a stent if you want to, if it didn't work, but you can give the patient a chance, and patient doesn't want stents. They rather have leave nothing behind.
Hello, everyone. Welcome to another episode of BackTable Cardiology podcast. I'm your host, Dr. Sameh Sayfo, interventional cardiologist from Baylor's Conway the Heart Hospital, Plano, from Dallas, Texas. I'm honored and privileged to have our esteemed guest, Dr. Ron Waksman. He is well internationally known, not only a clinician cardiologist, but also a scientist. Dr. Waksman is an associate director at Division of Cardiology at MidStar Washington Hospital Center. He's also the Director of Cardiovascular Research and Advanced Education. He is a clinical professor of medicine at Georgetown University. We all know him from the many trials that he was a national PI on, but he also a course director for an annual CRT meeting that all of us attend and enjoy. Dr. Waksman, we're really honored to have you here today, and thank you for joining us today.
Thanks to Dr. Sayfo for the opportunity. Glad to be here.
So the purpose of talking about this episode is to discuss drug-coating balloon in the coronary. But before we start there, you have pioneered a lot of technologies. You've been national PI on many studies. The old traditional therapy, when the angioplasty started, which is the balloon angioplasty, traditional balloon angioplasty, most of our audience are younger physicians that start their career with knowing what drug-eluting stent is. Can you talk us through the history of balloon angioplasty, drug-eluting stent, and where we are now?
Thank you, Dr. Sayfo. So the initiation of balloon angioplasty was by Dr. Andreas Grunzig. His vision was to do what the surgeons do, but percutaneously, minimally invasive. And the idea was to take a balloon, a tiny balloon, and to dilate the lesion and to open the blockage. Later on, it was developed to stenting and atherectomies and other devices. But it all fell within the percutaneous coronary intervention, what we called PCI. But coincide with that, we had restenosis, which means recurrence of the stenosis. And a question, why is that? Because we've been traveling on restenosis from the first time that we did balloon angioplasty. And the reason is because when you injure the vessel, when you're doing balloon angioplasty, you have healing response. The healing response basically creating healing with smooth muscle cells, some matrix, which build up again the plaque again. And that is an issue because we don't know how to treat it. Luckily, it doesn't happen in all the patients. With balloon angioplasty, it was up to 30% of the patients. With bare metal stents, maybe 15% of the patients. And this is all within 6 months. And now with drug-eluting stents, we see it less than 5% within a year. So we made a lot of progress, but we had to place a stent in most of the cases. As a matter of fact, 90% of the angioplasty today are done with stents. And you ask yourself, why should we cage the vessels with a metallic prosthesis? There are 2 reasons to do stents. One, to tackle dissections, which was another issue that we have seen with balloon angioplasty, and to prevent abrupt closure of the vessel. But that's really a rare event today. The second thing was basically to prevent the restenosis, to cut it from 30% to 15%. And the question was, all the time, can we do it without the stents? Because what's wrong with stents? Stents are foreign body. They are metallic. They're creating chronic inflammation. They can cause restenosis, also stent thrombosis. And also, we see, even with the latest and greatest stents, every year, from the time that you place the stent, there's about 2% recurrence rate or event related to the stent. So if you look about 5, 6, 10 years, you're going to go up to 20% event rate. So the question, can we get rid of the stents? But that's basically history. We moved from balloon angioplasty, bare metal stents, drug-eluting stents, with the question, are we committed to stents? Is there any better way to do that?
I think that's amazing to listen to. But the other question I have before we go to the technology, to the data, is what we call the art of balloon angioplasty. Can you talk us through, if you want to do just balloon angioplasty, what's your recommendation, how someone should do it? No, I'm not talking about DCB, I'm just talking about the good balloon angioplasty. Because now we depend on, we're going to put a stent anyway. So can you comment about this?
Yeah, it's a very good question and relevant question, because over the years, some people said, let's do direct stenting. We don't even do any balloon angioplasty. And that was a little bit overreaction to the enthusiasm of the stents. But we're going back to preparation of the vessel. And that comes to good balloon angioplasty technique. So when you see a lesion, we usually recommend to do imaging guided to understand the size of the vessel, the length of the lesion, and it's also the morphology of the lesion. Is this a calcified lesion? If this is fibrotic, or this is just lipid core? It's nice to have this knowledge. Usually, you start with predilatation. The predilatation allows you to facilitate a larger balloon or a stent, or if you're confident enough, you can go with the ultimate balloon. But the problem with balloon is that many of the, I would say, maybe young generation, they just inflate and deflate it. But if you really want to have a good result, you have to keep the balloon inflated for at least 20 up to 30 seconds to have a good result. Because two issues with balloon. If you oversize, you will create dissection. If you undersize, you're not going to diet. Even if you properly size, but you do it in and out, inflation, deflation, you're going to get recoil. And these are also components of what we're seeing later on of complication of balloon angioplasty or restenosis. So when you ask me today the art of balloon angioplasty, I need to know what I'm dealing with. The size, the length, the composition of the plaque, whether I can go directly with the balloon size that is fitting to the vessel size. I really don't want to overstretch the vessel, because the reaction would be with exuberant healing and restenosis.
So if I hear you correctly, imaging is crucial, sizing is important, inflation should not be quick, and just let the balloon does what the balloon's supposed to do.
That is correct. But the truth of the matter, today, balloon alone is used maybe in very small vessels because we don't want to stack a stent there. And what I learned over the years, that the longer the inflation, the better outcome that you have. You have to, it's like almost, you have to plastify the vessel, and you need to get some time to relax the smooth muscle cells, because when you injure something, immediately the reaction is spasm, right? The smooth muscle cells want to contract. You have to break that cycle. So longer inflations are better than in and out or quick inflation deflation.
So traditionally, we put a drug-eluting stent. A few years back, the bioabsorbable scaffold came to the market. There was a lot of excitement about it. It panned out, unfortunately. There's some risk for scaffold thrombosis, came out of the market. And now we're talking about drug-eluting balloon. Can you tell the audience who doesn't know either technology, what's the difference between a bioabsorbable scaffold versus a drug-coating balloon?
So bioabsorbable scaffolds are still scaffolds. You can call it scaffold, you can call it stent. It is still scaffold or stent, but they don't stay there forever. That depends on what is the material that is eventually will be bioabsorbed or bioresorbed, any way you want to, or corrode. It depends on the material. If this is magnesium, we call it corrosion. If this is a PLLA, which is kind of plastic, it's more absorption. And they have different lifetime. PLLA, plastic, may take up to 2-3 years to be completely resorbed. So you're fooling yourself if you're thinking, I'm not leaving anything behind. You are leaving for a period of 2-3 years, which is still prone the vessel to complications. With magnesium, which is another alloy that tends to resorb, it takes about a year, 12 months. But during that period, you still have scaffold. The advantage that you get a stent-like result upon deployment. The disadvantage that you still have to carry the stent adverse events until the bioresorbable scaffold completely resorb. Drug-coated balloon offer you from immediately the procedure, nothing left behind. You take the balloon, you deliver the drug into the vessel wall to prevent restenosis. Same like what the stent does, but the stent does it more by elution. The coated balloon are coated with the drug with some excipient that helps to the drug to attach to the vessel wall. But there is a distinction because some drug-coated balloon are actually eluting the drug from a polymer or from a microreservoir. So on this technology, some call it drug-coated balloon, some call it drug-eluting balloon. With stents, it's always drug-eluting stents, although there are some drug-coated stents as well. But what is the difference? The difference is with drug-coated balloon, nothing left behind except for the drug. And if the drug stays there for a few weeks, sometimes months, it has the same effect that the stent does. So you can basically prevent from the tissue to regrow. And if you got a nice result with balloon angioplasty before and drug-coated balloon to follow, you basically going to have opening of the vessel without committing to a permanent prosthesis. So that's pretty much the difference between them. But as you alluded before, the bioresorbable scaffolds had some issues with the start of the launch, with some problems like thrombosis and some restenosis and inflammation. So that's why I think individuals were more interested in going with something different, which is drug-coated balloon.
So, Dr. Waksman, you just mentioned the bioabsorbable scaffold. Now we have drug-eluting balloons. Currently in the U.S., we have one trial that was published, the Agent IDE trial, and that what brought drug-coating balloon to basically the market for instant restenosis. What do you think about the trial, and what do you think the effect of having finally a commercially available for instant restenosis in our daily practice? Are you seeing a difference in practice nowadays in Washington or across the country?
So the way the drug-coated balloon were introduced into the U.S. was through trials. The first indication was instant restenosis, which we were treating with brachytherapy, with another drug-eluting stent, but we were looking for something simpler, like the Europeans or rest of the world is using drug-coated balloons. So the agent was a Paclitaxel-coated drug-coated balloon, and it actually was studied against POBA, which is just regular balloon for instant restenosis. So this is a little bit troubling me because the POBA is not the way that we treat instant restenosis anymore. We're using it either drug-eluting stent or brachytherapy, and it was a very weak competitor, but not surprisingly, the drug-coated balloon was superior, as it should, to the POBA, which is plain old balloon angioplasty, and based on very good results, it was approved for marketing. So it is approved for marketing, but it is costly. It costs nearly $6,000 a piece. And if you have a long lesion, you have to use two, it can cost me even more. So I'm not going to go to all the reimbursement, but there are some reimbursement primarily for inpatient and outpatient. They are different. There are some codes of reimbursement that coming along. But as physicians, we do what is good for the patients. And for many of us, we are choosing right now drug-coated balloon when we see a patient with instant restenosis because we know that maybe outside of a brachytherapy, which very few centers have, or another stent, drug-eluting stent, this is a very safe and effective therapy. So that is becoming to disseminate into practices across the country. But side in side, we are actually testing drug-coated balloon today, not only for the instant restenosis indication, but also for the novo lesions, primarily for small vessel, where we don't want to put a stent. And I think that's the biggest opportunity, leave nothing behind, have the ability to use drug-coated balloon for the novo lesions, so we won't have instant restenosis. Instant restenosis is a disease of a stent. So if we treat everybody with drug-coated balloon, we're not going to have in-stent restenosis. But the whole issue of leave nothing behind, that's the new promise of interventional cardiology. I'm not saying you'll do it in all the cases because stents are still good and they're getting better. But we're starting with small vessels and we'll go probably to intermediate sized vessels. And in some cases, it will replace also large vessels. With respect to in-stent restenosis, we'll have to treat all the in-stent restenosis until hopefully we won't see anymore. But that's the easiest, safe technology that we have today.
Dr. Waksman, you are the national PI for solution the Novo Trial for balloon, and it's a limus balloon. And you just mentioned the agent is a Paclitaxel. For the audience who doesn't know the difference, can you just explain to us what the difference between the two drugs that's being eluted to the body?
Yeah, so all what we know goes back to the stent technology. We used to have stent with Paclitaxel, and then they were replaced with stent with the limus. And why is that? Because the limus is much more forgiving drug. It gives you a nice anti-inflammatory effect, no toxicity. You have a very wide range. You're not like worried about giving a little bit too much or a little bit too little. It's a very forgiving drug with that respect, and became actually the standard drug that we give right now for drug-eluting stent. The whole drug-eluting stents that with Paclitaxel were basically became obsolete because on the head-to-head trials when we had the stents, the Sirolumus or limus drug-eluting stents were superior to Paclitaxel. Now, we don't have a study like that in drug-coated balloon, but it appeared that it's going to be safer. I'll add one more thing. Paclitaxel is cytotoxic drug, and Sirolumus is cytostatic, so it's not a toxic drug to the vessel wall. So potentially it's much more promising.
Our colleague in Europe that you know very well has been using drug-eluting balloon for a while now. They actually have, 5 or 6 different companies where they can pick and choose what they want. You're familiar with all the data from there. Is it promising data? And why Europe is ahead of the US in this specific field?
So, the USA regulatory requirements are much more rigorous, and they requiring a large randomized clinical trials. In Europe, you can get approved based on some small registries. So the sponsors were hesitant to go to that investment in the US until Agent was the first one, but the solution actually was completed enrollment also for in-stent restenosis, and immediately was the first in the US to do a study for de novo lesions. So I think the companies now understand that there is a need to do that, and sure enough, other companies are in line in the US in large clinical trials. And in Europe, primarily it's being used right now for in-stent restenosis. We're still waiting for the large randomized trial, with actually using solution formulation for de novo lesions. This study enrolled over 3,000 patients head-to-head with drug-eluting stent. Now, if this study will show non-inferiority to drug-eluting stent, you understand that it's winner. It's winning if you are as good as stent without putting the stents. So we hope that that's going to be the case. It requires a little bit more work because you have to do a good vessel preparation with balloon. You have to choose who should be the right lesion and the patient for this. But in Europe, they went even one more step further with their solution, the Novo study, because they did all comers. So this data probably will be presented in October this year, and it's going to be making a big difference if we really see that they are non-inferior to drug-eluting stent.
And for the audience who doesn't know, when we say small vessel, is that a 2.5 millimeter or 3 millimeter? What's small vessel, and what other indication do you think when it's become available, if someone still want to do stent, what other indication like branches, CTOs, where do you think that's going to be used?
So by definition, FDA agreed that 275 and below considered to be small vessel. As long as you don't use a large or a 3.0 balloon, you can still consider that as a small vessel. Other indication, bifurcation, side branches, we are looking on even acute MI potentially, because again, we don't want to have stent thrombosis. We don't want to have stent restenosis. If you're not going to put a stent, you're not going to have stent thrombosis or stent restenosis. CTO is another opportunity, But each of one of those indications has to be supported by data. I mean, we are data-driven. No one is going to switch immediately without data. What is nice about that European study with Solution, it's all comers. So we would know subsets of patients with different types. They're including CTO, they're including AMI, they're including everybody. So we will get at least, maybe it's not going to be powered, but it will give us an indication if this is really works to substitute most of the stent that we're using today. Now, the optimistic says drug-coated balloon will replace stent. The pessimistic said, forget it. I think we have to be realistic, but I think if we learn how to do it, 30% substituting stents today with drug-coated balloon is very realistic. I think for instant restenosis, maybe it's 80%, but instant restenosis is only 10% of the market. So we really have to look on de novo and remember the mantra, leave nothing behind. If you leave something behind, it's always an issue. If you do it with drug-coated balloon, you can still put a stent if you want to, if it didn't work, but you can give the patient a chance, and patient doesn't want stents. They rather have leave nothing behind.
It's fascinating. This mantra has been mentioned maybe 12 to 13 years ago when drug-coating balloon was presented to the peripheral world. And that's exactly the same mantra. It leaves nothing behind. Patient needs a bypass in the future. You're not putting that. And we're 12 years later, and still, unfortunately, we're still getting a lot of operators who just prefer stents. They don't recognize that not every dissection require intervention. What will be your couple of words of wisdom for operators who's going to start using drug-eluting balloon in the near future? How can we train our upcoming physician who's going to adopt this technology? What's the right way for us to teach them the right way so they can leave type B dissection behind? They can leave 10% residual behind. What do you recommend?
So first and foremost, I want to just go back to drug-coated balloon in periphery. In SFA today, we're not putting stents anymore. It's all about drug-coated balloon. This is the mainstream device. Speaking of which, the best result that we have in the market for drug-coated balloon is with the solution in the SFA compared to all the others, Paclitaxel. That's another clue that the Sirolumus will work. But going back to your question, it's all about how we started. How do you do a good angioplasty with balloon? How do you do good vessel preparation? Don't get scared if you see a non-limiting dissection. You don't have to rush to open it. As a matter of fact, those studies were leaving a lot of dissections. In the US trial, we are under 10% of converting to stents. In the European, they started with 30%, they went down to 15%, and they didn't have to stop the study. The DSMB allowed to continue. That means they didn't have any issues with leaving dissections alone. The vessel usually heals by itself, and if you do a good angioplasty, you can do it without the stent. The other 10 to 12% are those that you really have a nasty dissection. On those, yes, if you're not comfortable, put a stent. But for the most patients, if you do good vessel preparations, calcified lesions, not blowing the vessel with balloon, you're probably going to get a good result, which you can end with 30 seconds inflation of drug-coated balloon. That's definitely guarantee you're going to have a long inflation for the lesion. So that's all what you need to do. And it's a lot of training and changing the culture of how we're doing angioplasty. But I believe truly that it's worth it. We need to see if the study will reassure us that this is the case.
Excellent. So what I hear from you is that the more you do, the more you learn. So, and become the more expert in it, you can now leave it behind. But you mentioned something extremely important is education. You've been pioneer for education. You've been an internationally known. You're the director of CRT annual meeting. And I want to ask you to tell us 2026 CRT, what's holding? Do you think DEB or DCB is going to big there? And can you give us maybe an insight about who's going to be the key speaker for the upcoming year?
I cannot do it publicly yet, but it's going to be a lot about drug-coated balloon, trust me. So that's going to be definitely one of the highlights because we have results of 2 studies. So we'll focus a lot on drug-coated balloon, try to see how they transition, because we believe that in 2026, we're going to get approval of the solution if the study shows, and maybe we'll get close to approval of at least finishing our de novo lesions. So I think there is a transition right now into that, and that will be one of the focuses of CRT.
So what I'm hearing from you is education is important, training is important. Do you think that maybe a conversation with the industry should be happening now where not just after that trial is accepted or approved or the product is approved, just not just flooding the market with the product without educating physician how to do it correctly? Because I think bioabsorbable scaffold, that's what happened. We had that study, maybe some did an IVUS, then post-dilate. So how important it is for the industry leaders in the field like yourself to partner together to educate our colleagues on the right appropriate way of treating those lesions with this technology?
We have to walk the walk, and we have to be very careful not to jump on every lesion. We have to get confident in the device, know the boundaries and the limitation, what can we do and what we cannot do. But I'm optimistic it's going to be much easier than drug-coated balloon. Imaging is important, but I think this technology is much more forgiving than scaffolds, the experience that we had before, and we have probably good adoption if we'll train individuals to do good vessel preparation.
Well, thank you so much for all this insight. I want to have one last question that's not related about DEB, not related about DCB. You have, every year, you've been surprising us with more amazing talks during CRT. You're interviewing some really public figures, internationally known, from athlete to politician. So for the young generation who are pursuing more interviews and things, what's your word of wisdom of performing the right interview?
Wow, learn a lot. You have to read the books, follow their speeches, at least the politician. I must say that if you really want, I can release it, but we're most likely going to have President Biden, which is going to be a challenge by itself, but I cannot commit 100%. So, but you read everything about the books, the speeches, their interviews, and you get to extract the best of it. But like everything else, if you want to be good at something, it requires a lot of preparation. So that's what we do when we interview everybody. Even Caitlin Clark last year, I have to learn all the basketball issues to be competent in asking her the questions. But at the end of the day, I told my friend Patrick Sorois, it's like I'm interviewing a patient. So you have a discussion with your patient and you ask him different questions and you forget for a moment that he is a president or a basketball star or whoever he is, and you let that discussion flow.
That's amazing. Well, thank you so much for taking time of your busy schedule. I really appreciate it. This has been very helpful and effective, and I think a lot of our audience will learn a lot from it. Looking forward to hear about the upcoming trial's result and maybe have you back on this podcast to discuss the result after it comes out. Thank you so much for joining us today.
Thanks for having me. My pleasure.
Thank you so much for joining us on BackTable Cardiology.
If you have not already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend.
If you have any questions or comments, direct message us at _BackTableCards
on Instagram, LinkedIn, X, TikTok, Blue Sky, or YouTube.
BackTable is hosted by Hadi Lisha
and Sameh Sayfo.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for tuning in.
We'll see you next time.